Yeah,
Yeah,
now it's
now it is okay.
yeah, it's live stream now.
Yes, yes, meeting is live stream now. Is it?
Yes, sir. Always live stream.
Yeah, we are live, sir.
Okay, thank you, Sandeep. Good evening, everyone. I welcome all of you for our monthly Indian Arthroscopy Society Academic Corner meeting for the month of June. We are going well with this program for the almost more than last 1 year. And for this month, today, we have two elegant moderators who happily agreed to moderate this entire session. I thank Tanmay Chaudhary, who was a former EC member of General Council member of Indian Arthroscopy Society, and he was a well-known arthroscopic surgeon in Indore, and he was trained with well-known our Coimbatore Dr. David Rajan sir in 2008, and is a known national faculty in all the cadavers and national programs of arthroscopy meetings. I welcome Tanmay to moderate the session. At the same time, I thank Dr. John T. John from Cochin. He's a well-known name in Kerala and as well as Indian arthroscopic circle. He's an FRCS from trained in the UK, and he's a national faculty as well as the local faculty in both arthroscopy and arthroplasty. And I welcome John also to moderate the entire session. With this note, I hand over this to Dr. Tanmay to introduce the speakers and go ahead with, and John also will co-moderate this session. Thank you. Over to Tanmay.
Thank you, sir. Thank you, Secretary, sir. Dr. Sundar. We have our esteemed faculty with us tonight, Dr. K. N. Subramanian from Madurai, who is a well-known national, international figure in arthroscopy. He is a senior consultant orthopedic surgeon and with special interest in arthroscopy and shoulder surgery at the Vellamal Hospitals and Vale Specialty Ortho Center at Madurai. He is the director as well there. And he is a visiting consultant at this Spurge Hospitals, Bangalore. He's the past president and past secretary of the TNS, the Tamil Nadu Arthroscopy Society. He was there, carried over for 4 years, for 2015 to 19. He was the past secretary of the Madurai Orthopedic Society till 2020, associate vice president of the Madurai District Football Association, past EC member of the SESI, then EC member of the Tamil Nadu Orthopedic Association. Yes, numerous articles in peer-reviewed journals, and he's the course director of a very famous Madurai Shoulder Knee Conference, which has been consecutively conducted for the last 6 years. He's honored with Medical Excellence Award in Shoulder Specialty by the Indian Solidarity Council, a regular author of public awareness article for magazines, and he written chapter in disorders of shoulder surgery, shoulder injuries in volleyball as well. So I invite Dr. K. N. Subramaniam for delivering his first talk. We have two case presenters as well today. One is Dr. Raghavan from Karnataka. He's an associate professor at the B.M. Patil Medical College and Research Center at Bijapur. He was an ex-SICART fellow in arthroplasty and reconstructive surgery and shoulder arthroscopy. So, and we have Dr. Shripath Joshi. He is also, he is presently working at Pune. He's is an associate professor, in Aurangabad as of now, at Aurangabad. Apologies. So he has a lot of paper presentations and research work over the last few years. He's a regular, attended many conferences and given many presentations. He has experience of more than 7,000 arthroscopic surgeries, knee and shoulder and elbow as well, and STO surgeries as well, plus wrist and complex surgeries. So I invite you all for starting this session. Just invite him to start his talk. Over to Dr. Subramaniam.
Thank you. Can you hear me?
Yeah, we can hear
we
you
can.
very well.
Okay. Let me go to the share screen mode.
Hello.
Hi.
Shripod, we can hear you very well. Can you mute yourself? Yeah, you can go ahead.
Okay. Thank you. Thank you, Dr. Tanmay Chaudhary and Dr. John T. John for introducing me. And thank you, current President of IAS, Dr. Sachin Tapasri, and Dr. S.R. Sundarajan, Secretary of IAS this year. And thank you all the audience. And the topic they have given me is partial rotator cuff tear, whether to repair or rehab. It's always an interesting topic, this one, because even an experienced surgeon gets a confusion whether this cuff tear will heal or not, do we need surgery or not. It's always been a big question. And let's try to summarize in a way that we can make sure we can make some important points about it. So let me start from very basic thing. Sorry, can you hear?
Yes, we can hear you, sir. Yes, we can hear you.
So basically, we come across pathologies like cuff tendinosis, intrasubstance tear, partial cuff tear, which is dorsal tear or articular surface tear, or a full thickness cuff tear. I want to mention that this is a spectrum of same pathology being presented at various stages.
I would request others to mute themselves, please.
I think it's some. Who is this? Arun Gupta. Who is that? Sandeep, can you remove?
Can you mute everyone for the...
Just a minute, Subramaniam, sorry.
Okay. So it's important one has to understand the function of the rotator cuff. It's actually a good stabilizer for the humeral head, which makes sure it always stays against the glenoid in whatever movement that we are doing. So it can be called as a dynamic stabilizer, and it is important for giving the concavity compression effect, and it can also be seen as a power generator for the shoulder joint. So if this shoulder rotator cuff is not functioning, then what will happen is the thing is that one has to understand. So biomechanics of the shoulder gets disrupted heavily, and subtle anterior superior escape starts occurring in the initial presentation itself. The first symptom will be slight escape of the shoulder joint anterior superiorly, and to compensate that, scapular dyskinesia starts happening. And it's very common to see scapular dyskinesia in every patient coming with any rotator cuff problem, whether it's a partial tear or even full thickness tear. They all invariably have an element of scapular dyskinesia. We look into the etiology of the partial cuff tear. You can point it out to some of the problems that one can come across, like overhead stress due to overhead athlete, like a tennis player or any overhead sports player, like volleyball player, basketball player. And there may be a predisposition to an anatomic morphological changes in the acromion. So there are three types of acromion as we know of. Type 1 is flat and type 3 is hooked. There's a good higher incidence of cuff tear in patients who are having a type 3 tear, which is like almost up to 73% of the rotator cuff tears can have a hook type of acromion. And a lot of these pathologies occur around the age of 40 or 45 or more than that, which indicates that it is a pathology of degeneration rather than just a trauma or due to any anatomic alteration in there. And direct trauma is one another pathology which can cause rotator cuff tear. One has to remember that not always a single factor, it can be multifactorial, which is the reason for people having either a partial cuff tear or a full thickness cuff tear. So I have to emphasize this kinetic chain. So in an overhead athlete, for example, somebody is throwing a ball, and about 50% of force is coming from the leg and trunk and back. About 30% comes from shoulder, and 10% comes from elbow, and 10% comes from wrist. So if you are throwing a Newton of 1000 Newton, only 300 Newton is coming from the shoulder joint. Remaining all is coming from other parts of the body. So for example, if somebody is core muscles are not good enough, then automatically they are going to put pressure on other areas to generate the same force. So if, for example, the trunk muscle is not good enough, then they'll put more pressure on the shoulder joint, and hence they have a higher chance of developing a partial cuff tear or even full thickness tear. So this is a basic concept, and one has to understand that very heavily to understand how the mechanics of partial cuff tear works. So if you took on the clinical features, most of them will have shoulder pain, often localized to lateral deltoid, which gets aggravated with the is a night pain. They are having night pain, then they are having significant symptom, and they may need some kind of intervention, or they need aggressive physiotherapy, or they may need even surgical intervention also. And weakness may be there depending on the pain. A partial cuff tear can also be weak due to pain inhibition, and full thickness cuff tear can also have weakness. So, and the pain which was episodic initially will becomes constant, and they will develop activity-related pain in terms of doing overhead activities. And the pain is more often located in the superior and lateral aspect of the arm region. The classic test is Hawkins test, where you try to flex the shoulder joint and internal rotate, and the patient comes with pain. Or knees test, where you try to internal rotate the shoulder joint and do flexion more than 90 degrees, they get pain over the anterior aspect of the shoulder joint. And Job's test is where it's an empty can test. You try to keep the arm in the scapular plane and do abduction along the movement along about 30 to 40 degrees, and they develop pain, then they are having tendinitis. They are having loss of function, then they are having a full tear of the rotator cuff muscle. This is what indicates in Job's test. So if you look into the partial tear, in fact, if you look into the footprint of the supraspinatus and infraspinatus, it is a wide dimension. It ranges from 16 mm medial lateral width to anteroposterior width is around 32 mm, or even up to 38 mm is there. So it's not a single point attachment. So a partial tear can be a small tear occurring one part of the rotator cuff, or even the posterior part, or anterior part, or medial part, or lateral part, but more likely it occurs around the area of degeneration, which is the watershed area, which is about half centimeter, just proximal to the insertional area. That's where the typical partial thickness cuff tear occurs. It can be due to external impingement, where you will see a bursal type of tear, or it can be intra-articular petal, where you will see a articular surface type of tear, where it is called as partial articular surface tendon avulsion. So a full thickness cuff tear can be a small tear, medium tear, a large tear, a massive tear. A massive tear is something which has gone beyond the glenoid, and medium tear is where it has gone up to the middle of the head of the humerus. And small tear is ranging in the footprint area itself. The footprint area itself is about 1 to 1.5 centimeter. If it is just over the footprint area, it's called a small tear. Yeah. So how will you manage a partial thickness cuff tear is a question that we are going to answer for today's talk. And the first thing I told you is that anyone coming with a severe pain in the shoulder, Hawkins positive, night pain, and range of movement is altered, I look for scapular dyskinesia. For example, if you look into these patients, this patient has got a almost complete range of movement. Abduction is there, flexion is there. You see his scapula. Each time he's doing the movement, the scapula is slightly altered in morphology. He lifts the scapula slowly and then does feature of capsulopathy also, and the MRI shows a partial tear. This kind of patient, first thing is you have to do scapular dyskinesia correction. So what you do is correct the core stabilizers and scapular rhythm. There are 6 group of muscle that helps for core stabilization of the scapula, and they are the anterior deltoid, lat dorsi and levator, lower and middle trapezius, rhomboid, teres major, and serratus anterior. And if somebody focuses on these muscles and get good rehabilitation, there's a good chance the scapular dyskinesia will become much better, and the symptoms will also get better. And the adhesive capsulitis can be improved by doing stretching exercise also. For example, this patient has got a scapular elevation, as you can see when you're doing a Hawkins test. The right shoulder is a pathological shoulder, left shoulder is a normal shoulder. If you see that when I do the right shoulder Hawkins test, he elevates the scapula each time. That indicates that his scapula is having dyskinesia, and he also has got rotator cuff tendinosis or a partial tear in the MRI scan. He does not need any surgery at all. What he needs is a good rehab, After rehab, as you can see, this is the pre-rehab, this picture is, and then he has undergone with about 8 weeks of full rehabilitation for the right shoulder, strengthening all the core muscles, and you can see that this one, where after rehab, pain all disappear, and this is not eliminated. The first and foremost treatment for any patient who is coming with a partial is that you need to do good rehabilitation. That will help for his symptoms to improve because his scapular dyskinesia gets better. Another important thing is look for scapular dyskinesia or alteration in the prominence of the scapula. There are 3 types of axial scapular dyskinesia. This is like type 2 where inferior medial border is what you can do is try to correct the deformity by putting the symptoms get better. That can be called as scapular assistance test. Symptoms get better after doing the deformity correction by holding the finger. Is going to improve the symptoms. Scapular assistance test right candidate for doing rehabilitation. MRI is showing the vascular patient and the symptoms are totally better. So that's the next thing to be aware of. So this is a very important that I want to emphasize is what happens in scapular dyskinesia is the scapula tilts anteriorly like this. When you have a tilting anterior like this, the subacromial space actually becomes little more narrower, which causes pain into the subacromial area, and they develop partial cuff tear and also pain. It's like a vicious cycle. Scapular tilt causing partial cuff tear and partial cuff tear also causing scapular dyskinesia. Both occurs like a vicious cycle, and hence, if you correct this scapular dyskinesia well, this space between the acromion and the head of the greater tuberosity becomes a little wider also, and the symptoms also will disappear. So the most important take-home message for me today is, if you do the rehab correctly, the patient's symptoms will improve because the anterior tilting of scapula will get corrected. When I use subacromial injection, it can be helpful in some certain patients where the pain does not get better, or even the pain is much more worse after doing a rehab, or is not to facilitate rehab, you can do subacromial injection. But beware that subacromial injection has got a small chance of having a full thickness cuff tear if there is a partial cuff tear. So in fact, there are papers which indicate about 17% chance of having a full thickness cuff tear. But in spite of that, when you look into the literature, still a lot of people practice injection. So doing one injection is not harmful. You can give one injection if you need for rehabilitation purpose only. So for example, this one, if you can see that this patient also has got a partial tear, and partial tear is almost into the bursal area, as you can see over here. And he has got a severe Hawkins stress positive. He got excruciating pain, and Jobs is also positive for pain. The flexion interrelation of shoulder is severely painful. He underwent physiotherapy. In spite of rehab, he keeps on having pain with night pain present. Then they are a candidate who may need surgical intervention. In spite of this being a partial tear, they will need surgical intervention. As you can see that we have done just acromioplasty, and then the partial thickness cuff tear was converted into full thickness cuff tear. You can see there is a small tear there, and that cuff tear was repaired, and he got better with the symptoms. So indication for surgery in a patient who is having a partial tear is failure of rehabilitation. There is a failure of rehabilitation, and the tear which is almost like a near full thickness tear, then they are only going to get better with surgery, and where you can do and go and do rehab, and the pain will get better. This is another scenario. It's a traumatic. 37-year-old child fell off a ladder, pain in the shoulder. He is not able to active elevation because and he can do with the help of the other arm. Actually, he is able to do but actively he cannot do it. This is a clear sign of a almost near full thickness rotator cuff tear. And what is the management pattern for this is get an MRI, make sure the quality of the muscle is very good, and then if you do, can you do conservative treatment in this kind of scenario? You can see articles mentioning very well that a full thickness cuff tear, which is of traumatic origin, will have an excellent benefit if you go on to repair it. So these are the clear-cut indication for doing a surgical repair. So arthroscopic cuff repair will give a almost near more than 95% of the time they will have a very good success rate. And you can see that every full thickness cuff tear, except for the acute traumatic tear, can be tied with rehabilitation. But if it is a traumatic tear in younger chap, go for surgery, the success rate is very, very good. So treatment of full thickness traumatic radial cavity is usually repair early and also do robust repair like double row repair, and you can rehabilitate very quickly and the outcome is going to be phenomenal also. So next scenario is like where there's a partial cuff tear, almost like a partial cuff tear here, but the patient has tried exercise for almost 4 months time, still having pain, then they have to be undergo surgery also. Here, when you ask the patient lift the arm, use the other arm to elevate it, which means they're having a cuff tear only. So the treatment for this is to do cuff repair, and after the cuff repair, the patient will do that better. And, the point is to failure of rehab in a tear which is almost near full thickness tear is definitely have a better benefit in the surgical repair. And now coming with the full thickness tear like this is coming away from partial cuff tear, like a 50-year-old or any middle age one, trivial trauma 2 months ago, muscle quality not bad, retraction only around 3 centimeter. It's better to repair them sooner because if you leave it, they are going to progress it and make it worse and come back. So anyone with 3 centimeter retraction already had rehab, definitely go for repair. They will definitely come with a better outcome only. I'll give this kind of scenario where you should not repair it. Like this patient is 72-year-old, tried physio already, trivial trauma, not able to lift shoulder actively. An X-ray shows already early evidence of OA. So any older patient, tear size large or massive, cuff quality poor, bone quality poor. Here, the problems of having failure of surgery is very, very high. All these criteria, elderly, tear retraction, tear size in epidermis is very wide. Infraspinatus having a fatty grade 3 or 4, low bone mineral density, high level of work of activity. All these are bad indicators for surgery because there is a very high risk of re-tear. If you can see the re-tear after surgery in these kind of individuals are very high, even up to about 84%. So these are the kind where you should think about not doing repair, but instead you should think about other options of surgery if they have pain like lat dorsal transfer or even going for reverse shoulder replacement. If they, because this patient already has got a osteoarthritis to the age of 72, then you should think about doing a reverse shoulder replacement for this patient. So just let me summarize what the take-home message is going to be. So asymptomatic partial tear or a full thickness tear which is asymptomatic, functionally compensated, then they don't need surgery. Just if they keep doing rehab exercises, they will do very well. So other group is a symptomatic partial tears or full tears or elderly individual functionally partially decompensated. I mean older individuals in the sense they are like 40 to 50 year old with good muscle quality. You try physio first, not getting better, then you go for a surgical repair. And if you look into the pattern of which one to rehab, advantage for rehab is no surgery, improvement in good proportion of patient. And disadvantage is that if there is a full thickness tear, we always have in the back of the mind the tear is going to progress and muscle atrophy is always a problem. But we have to keep an eye on these patients, see whether they are symptomatically improving and keep under regular follow-up also. And repair has got a good healing and good outcome. And disadvantage is, for example, like disadvantage if you do a repair, they can go for a re-tear sometimes. And very important thing I want to pass on this, explain the realistic outcome to the patient. Whenever you see a patient coming with a cuff tear, tell them the recovery is not going to be within few days or so like that. It's going to take about 2 to 3 months or even up to 6 months. And any patient who is coming for surgery, I tell them in 6 weeks time, they recover about 50%. And in 3 months time, they recover about 75%. And 6 months time, they recover about 95%. So if you tell them beforehand, their mind is prepared and their outcome is very well planned and they will get a better outcome also at the end. So with this, I will conclude my thought. So partial cuff tear, try rehab first. If they are not getting better with rehab, go for repair. Thank you very much. Thank you the whole Indian Arthro Society for giving this opportunity. I'm open for questions. Thank you.
Thank you. Subbu, can you stop sharing the screen? You're going to use the stop share.
Stop share?
Yeah. Thank you. Tanmay, there is a question in the chat box.
Yeah. This is from Dr. Udit Biswal. What's the ideal duration from trauma to cuff repair in case of a partial tear?
Really in a partial cuff tear, if the cuff tear partiality means it's less than like even 20% or 30%, I will not be going for surgery straight away anyway. I'll be planning for rehab only. And if a tear is like almost near full thickness tear, for example, like the example I showed you earlier, where is almost 80 to 90% of cuff tissue is gone, then I would go for a repair. And the repair, you don't have to wait like rough duration about 2 to 3 weeks, you can go and start repairing that. But it depends on how big is the partial cuff tear.
Is it the both for the same for the the articular surface or for the bursal surface you're talking?
Immaterial, whether it is a bursal tear or articular surface tear, nothing wrong in rehabbing for first few weeks. Some of them do get improvement. If after rehabbing also, if the pain is persisting, you can go for repair.
And for the degenerate tears, these kind of tears in the elderly people, how many percentage of cases do you go and do a tenotomy of the biceps?
Tenotomy.
Yeah.
Tenotomy is not a sole indication for any case. So if you are going for a surgical indication for other purpose, for example, like a cuff tear where you want to go into cuff, addressing the cuff, then you will go for tenotomy. So the group of people who are coming for this kind of things around the middle age group only. So chance of me doing tenotomy is very. Your question is like whether you do tenotomy or tenotomy. That's what your question is.
Yeah. I mean, what age group you would really define between tenotomy and tenodesis? What's your?
There is no such a kind of age group, but anyone like who is having partial cuff tear, not degenerative type of cuff tear, means they are having degenerative pathology. So okay. More of tenotomy than tenodesis. I will not be doing tenodesis for this individual. In a younger individual, like traumatic event, then we go for tenodesis, like 20-year-old, 30-year-old.
Okay, thank you.
Dr. Subramanian, I have a question. I'm Dr. John here.
Yeah.
Do you quantify the thickness of the tear with your radiologist? We do regularly.
No. I mean, so to quantify a tear, you need to see both coronal and sagittal pictures. Okay. And you can actually make it out how big it is by yourself. I usually don't. You can speak to radiologist if you wish, but you can quantify it by ourselves itself. Yeah. And
so how do you quantify your tears?
How do I quantify? So if you see any sagittal cut or any coronal cut is about 4 to 5 mm. Taken in images. Okay. Yeah. So if you are able to see a tear in more than 3 or 4 images, then you are talking about a tear dimension of about 1 to 1.5 centimeter, which means about 4 to 5 mm is each cut. So you have to see in sagittal and coronal to map out yourself how much tear dimension it is.
Can I ask John the same question?
Yeah. What we do that? Yeah. Tell me.
Yeah. Please. That's why I want to ask you. Do you quantify regularly? What is the concept behind that?
We quantify the tear thickness because the thickness of the cuff varies with person to person depending upon what was the level of activity he had.
Yeah.
So it depends upon the percentage of thickness of the tear, whether it is more than 50% or less than 50%. Then only we plan our treatment. If it is more than 50% tear in ultrasound, we have got a musculoskeletal radiologist. So she does all the ultrasound scans.
Yeah.
And if a symptomatic patient is having in ultrasound more than 50% thickness of a cuff is toned, then we'd go for an MRI quantification. If it is more than 75%
John, I agree with your point.
And less than.
I agree with your point. Okay. If it is only in one cut, more than 50%, then it is only like 5 mm tear maximum. Okay.
Yeah, even a very small tear can cause severe pain and disability also.
Yes.
Even a small tear.
So even a small tear of 1 dimension, I will not do surgery straight away. I'm definitely going for rehab only and see whether they have improvement of symptom. I think
John is speaking about a traumatic tear in a younger patients. They may have a lot of pain, like as you say, even the small tear, partial tear patients can have a pain.
Only yeah, so there what I was speaking is all these pasta lesions mostly are in younger patients with whom they are presenting, you know, around they will be around in 40s mostly. The
Yeah.
degenerative tests usually will be presenting more than 55 to 60.
Yeah.
So that people
Yeah,
are
agree. The age group is different. Okay, some of them around 30, 40. If you are seeing that kind of patients where due to traumatic event, then it may be better off going for repair, where you can do inside to repair or converting full thickness cuff tear and do repair, depending upon your preference. So it is like case to case selection, which one you are going to repair and which one you are going to rehab.
Like
A traumatic event without degeneration, you can repair will be a better option.
even what John says, many younger patients also we see sometimes lesions, like who are the gym guys, no? Some of the guys who lifts heavy weights, they whenever you do an MRI, they'll have some small pain, small tear. But yes, you said that if they rehabilitate, if you avoid that activity for some time, many patients will recover with the conservative management. Unless it's a full thickness tear, definitely, I mean, all of us agree that you should go for a surgery. Otherwise, we should always we try for a conservative trial, I think.
I think the message that we want to pass is a lot of patients present to us not straight away. A lot of them come after 4 to 6 weeks and all. Okay, yeah. And the first thing is rehab has got a role. That's what the message one has to understand. And even after rehab, they have continuing symptoms, then they are indication for surgery. Because rehab, I have a lot of patients who have improved with rehab without having surgery also. Traumatic is a different scenario. Even traumatic also, some of the patients have improved. But though they may not be having 100% improvement, they are to the improved to the level that they are happy with what they are living, like that.
There are other 3 questions in the chat box.
Yeah, there's.
Okay, go ahead, Tanmay.
Yeah, okay. There's one question between what's the difference? How do you clinically evaluate or differentiate between a subacromial bursitis and an atraumatic partial tear? They usually, mostly they have
So it is a partial tear is a symptom of a muscle or tendon. Bursa, it is a symptom of a bursa. Okay. So basically, just impingement positive. Hawkins says is only positive. Okay. Then you are having impingement definitely, which means bursitis is there. You are also having joke test positive with pain. Then they might be having an element of tendinitis or a partial tear also. So both positive, then you are thinking about a partial tear. Only one positive, it may be just bursitis. That is in clinical way you identify. But when you are going for intervention, you definitely look for investigation. We don't just go on a clinical examination. And then
another question from Dr. Silam Barasan that what's doing physio versus progression of the retraction? How do you balance the physio before cuff repair in case of full thickness tears?
Okay. Yeah, it's a very good question. Okay, because we always we are known that full thickness tear, they keep on progressing to bigger size as the days go by. And the percentage of it is around 30 to 40%, which means about 60% of tear may remain asymptomatic totally. Okay. And 40% will improve, will progress and make it more symptomatic and become worse. It's difficult to pinpoint which is going to progress, which is going to cause symptom. So my rough time scale for me is keep doing rehab for about 8 weeks time to 12 weeks time. Majority of the patients by 3 weeks itself, they'll come and say if they're having more symptoms, I'm not able to do any more physio. They're having night pain. Then I give a warning to them that try one more week, give an injection and see whether they get better. If they're not getting better, then they have to go for surgery. But if they are improving by 3 weeks time, they will continuously improve for next 12 weeks and they will get better totally. So rough timeline is about 8 to 12 weeks time to make a decision on whether they need to continue repair or continue rehab or go for repair.
Any role of biologics in the healing of partial tears?
That's totally a different subject by itself to answer. And I think the question is still answered in scientific base at this moment. I have used biologics on top of doing a repair, not just simply on by itself only. It has got some role. I think it has to be answered.
I think what he wants to know is whether PRP can be injected. I think
yes,
PRP. For the partial cuff tear.
Yeah, PRP. I mean, it's a 50-50 role. That's what I would say. Because not everybody gets benefit. Some of them will have increase of symptoms also after PRP. That's all happened to me in the past. Because PRP itself is it can cause some inflammation and they can cause increase of pain initially and then the pain will decrease later on. So it's personal choice only. But science is not fully supporting yet.
Right. Absolutely.
And if you are giving PRP, I feel you give ultrasound guidance so that you inject into that area. If possible.
Yeah.
Safe practice, ultrasound guided.
Yeah.
If you are, that makes you make sure that you are definitely in the place where you want to go. Yeah.
Thank you, Subramaniam. I think it's excellent discussions because it's an interesting topic for all the practicing surgeons, especially the partial cutters. Always it's a very debatable questions. I think it's generated a lot of questions, and I thank all the guys who are asked questions, and you, as usual, just cleared with your concepts. Thank you, Subramaniam.
Thank you.
I think we can take over the next talk. It's a case presentation from Dr. Raghavendra. Can you share your screen?
Yes, sir. Can you see my screen, sir?
Yeah.
Yeah.
Go ahead.
Good evening, everyone. I'm Dr. Raghavendra Kimbavi, working as Associate Professor in Sri B.M. Patil Medical College and Research Hospital, Bijapur, Karnataka. At the outset, I would like to thank Dr. Sachin Tapasvi sir and Dr. Sundarajan sir and IAS for giving this opportunity to present a case report on scapulothoracic arthroscopy. I would like to thank my colleagues, Dr. Shrikant Kulkarni, and for giving me this case, and Dr. Ravi Kumar Eli, who is my radiologist, for helping me in diagnosis. So this is a 26-year-old male patient presented with the cracking sounds, cracking sensations and sound along with the pain along the scapular border over 7 years. The crackling sensation or sound with the pain was insidious onset, gradually progressive, and there was no history of trauma. On examination, there were multiple palpable swellings along the medial border of scapula. There was tenderness on the superior medial border of scapula, spine, as well as inferior medial border of scapula. There were crepitus on forward flexion and scapular rotations, and patient also had pseudo-winging. On further examination, scapular position and movements were dyskinetic. However, there was no coracoid tenderness, no instability of the shoulder, and no distal neurovascular deficit. So this is a clinical picture showing scapula, and there were multiple swellings along the medial border of the scapula. And these were the movements. And the final terminal forward flexion showed dyskinetic scapular movements. Proceeding with the imaging, radiography was normal, both AP, axillary, as well as scapular Y views. So I went ahead and got MRI done. MRI showed bursitis of infraserratus bursa, trapezoid bursa, as well as sagittal sections showing infraserratus bursa. And there was hyperintense signals along all the way along the middle border of scapula, showing the inflammation. So my diagnosis was a snapping scapular syndrome due to recalcitrant scapulothoracic bursitis with scapular dyskinesia. I did try for 8 months of physiotherapy with aggressive rehabilitation, painkillers, and local ultrasound and short wave diathermy. However, patient didn't got relieved of the pain, so I had planned for a surgery with the arthroscopic bursoscopy and bursectomy of scapulothoracic bursa, both infraserratus and supraserratus. So this was my position, prone position with the chicken wing position of the arm. Used 2 portals, one superior scope portal and one inferior instrumental portal. So this is a intraoperative video showing lot of fibrinous adhesions in the bursae. This is quite unlike what we have in subacromial space. This is quite fibrinous and thick, like a spider web. So I had to spend a lot of time using the radio frequency here and cauterizing the vessels before going into shivers. So after cauterizing all the blood vessels, I did use a shaver for removing all the bursa. So as we can see here, a lot of thick fibrinous strands. So this is a picture before the bursectomy, and after bursectomy, we have a clear space between the muscle planes. Post-operative, nothing much. I did put 2 weeks of sling just for pain relief. Started with a range of movement after 5 days of surgery. I did particularly focus on scapular retractors at 0° axial rotation and 45° axial rotation. So this is a post-operative, 3 months post-operative. Patient movements were full, and patient was a gloomy patient, and he is smiling, completely relieved of all the crackling sensation and the pain. Coming to the discussion, snapping scapular syndrome is also defined as Washford syndrome, scapulothoracic syndrome, or scapulopostal syndrome. It is audible or palpable clicking of scapula during the movements of scapulothoracic joint. Scapulothoracic joint, we all know that it's peculiar joint, completely devoid of capsule and cartilage. It is well documented that it's commonly underdiagnosed and underreported, probably because we don't focus on the scapula on the back. We did, especially on the females, because we need to expose scapula completely. So we have an inclination for underdiagnosing this case. The causes of snapping scapular syndrome is 2 things. One is osseous, and another one is soft tissue lesions like scapulothoracic bursitis. It is scapulothoracic bursitis, biomechanical changes causing symptomatic inflammation of the bursa in the scapulothoracic joint. Osseous lesions, we have anatomical variations, which is superomedial angle of the scapula, which is normally an angle between superior border of scapula, the spine, and the inferior medial border of the scapula. Normally, this angle is around 125 to 160°. See, any acute angles of more than 125° can cause snapping scapula. Another important cause is the scapular exostosis on the ventral surface. Luschka tubercle, which is a bony projection, hook-like projection on the superior medial border of the scapula. It can cause snapping scapula as well. Malunion of scapular fractures or rib fracture can also cause snapping scapula. And the last one is spingal deformity. Scapular dyskinesia is another important causes of snapping scapula. It is a cause or consequence of many forms of shoulder pain or dysfunction. There are several causes for scapular dyskinesia, which can be articular causes, articulatory causes, musculoskeletal causes, neurological causes. So articulatory causes can be acromioclavicular arthritis or instability in the joint. Musculoskeletal causes can be thoracic kyphosis or non-union in the clavicle fractures, shortening or angulation of the clavicle. Neurological causes can be paralysis of nerves like spinal accessory nerve, 11th cranial nerve, or cervical radiculopathy. So that makes this entire syndrome as a constellation. Scapular syndrome is a consequence, or it results in a scapular dyskinesia, or scapular dyskinesia might result in snapping scapular syndrome as well. So whenever we have a case of snapping scapular syndrome, we have to rule out all the causes of scapular dyskinesia, which was mentioned in the previous slide. So in severe form of scapular dyskinesia, we have something called 6 scapula, which is defined as scapular malposition, prominence in the inferior medial border of scapula, anterior coracoid pain, and scapular dyskinesia. Coming to the soft tissue causes, it is usually 3 major bursae on the scapulothoracic region. One is infraserratus bursa, which is bursae between the rib cage and the serratus anterior under the serratus muscle. The supraserratus bursa, which is located between serratus anterior and subscapularis. Trapezoid bursa, which is under trapezius muscle and scapula. Clinical features presents with the pain during overhead activities, affects usually young and active patients. There are audible or and palpable crepitors during the shoulder movements, including the shrugging of the shoulder. And pain or snapping decreases when the patient crosses the arm, thus lifting the scapula from the rib cage. So patients usually shows symptoms of something called pseudo-winging. So this is a picture showing the pseudo-winging as a compensatory mechanism to just to alleviate the pain. Giovanni Merola, Dr. Giovanni Merola did describe the difference between pathological and physiological. So we have to be always careful of pathological as well as physiological snapping scapula. So all the patients who presents with snapping scapula without pain may be physiological, so doesn't need any intervention for such patients. However, patients with the symptomatic bursitis may not present with the crepitors, so we have to be careful in differentiating between pathological as well as physiological crepitors. Diagnosis, clinical examination is always paramount. Never forget to look scapula, so we always have to look for scapular position as well as scapular movements. Workup with the radiology, X-ray, look for osseous lesions in AP, axillary or scapular value, especially look for any osteochondroma or bony lesions, luscotubercle. CT quite helpful in assessing the scapular morphology. And MRI, of course, it is quite useful in soft tissue lesions, assessing soft tissue lesions like bursitis or soft tissue tumors like elastofibroma. Management, first thing is always conservative. We always have to try for conservative treatment for 3 to 6 months. If the conservative management fails, then go for a surgical management. Conservative management focuses on 3 things. One is muscular dysfunction. The second one is postural factors. The third one is scapular dyskinesia. In muscular muscles dysfunction, we have to strengthen the weaker muscles, which are serratus anterior, rhomboid major, rhomboid minor, mid and lower trapezius, posterior deltoid, infraspinatus, iris minor. The tighter muscles we have to stretch it, so which are levator scapulae, upper trapezius, subscapularis, latissimus dorsi, minor, and pectoralis major. We have to correct the postural factors as well, minimize the thoracic kyphosis, promote the upright posture of the patient, strengthen the upper thoracic muscles, and avoid the scapular, when it comes to scapular movements, avoid the scapular abduction as much as possible and encourage scapular adduction. So along with the rehab programs, we have to focus on the pain relief as well with the painkillers, NSAIDs, ice or heat, local ultrasound or diathermy. Corticosteroid injection, of course, it's very helpful when the lesion is localized. In my case, it was quite diffuse, so I didn't try for any corticosteroid injection. Surgical management, 2 options. We have open bursectomy or arthroscopic bursectomy with or without supromedial resection of the scapular margin. Arthroscopic bursectomy, of course, it has a lot of advantages over open, low invasiveness, decrease in the morbidity, preservation of the muscle attachments, early post-operative rehabilitation, good and of course, shorter hospital stay. Portals, 3 portals are useful. One is a scope portal, which is around 3 centimeter medial to the medial border of the scapula at the level of spine of scapula. The instrument portal is around 5 centimeter below the scope portal. And the third portal, which is quite very useful for resection of the superior medial border of the scapula, is Bell's portal. We have to be always careful of neurological structures in and around the scapula. First thing is dorsal scapular nerve, which is around 2 centimeter medial to the scapular border, medial border of the scapula. So our scope portal has to be 3 centimeter away from the medial border. The second one, which can be injured during the surgery, is a spinal accessory nerve. So we have to be careful in putting the scope or the instruments above the spine of scapula. So any instrument in this region can injure the spinal accessory nerve. The third one is suprascapular artery or nerve. So we have to avoid 2 lateralization of the scope or instrument, risking these structures. There are a lot of articles in snapping scapula syndrome. This is one of the review article published in 2021. And it clearly states that initial non-operative treatment was reported. This article reviewed around 40 articles, and it clearly stated that initial non-operative was reported as successful in most symptomatic patients with improved visual analog scale. And it states that 3 to 6 months of rehabilitation or conservative treatment has to be given before going for surgery. So in case of refractory patients, go for open or arthroscopic procedures with or without supromedial resection of the scapula. This is another article published in 2022, focused by Bassam El Hassan, focusing on the pectoralis minor release in case of tightness of a pectoralis minor and weakened serratus anterior. And the study clearly, in a study of 31 patients, it clearly stated that arthroscopic pectoralis minor has a role in a case of scapular dyskinesia, that is scapulothoracic abnormal motions. So to conclude, arthroscopic bursoscopy and bursectomy is quite useful procedure in recalcitrant scapulothoracic bursitis with failed conservative management. Thank you.
Thank you, Dr. Raghavan.
Yes, sir.
Tanmay, I think is some net issue. Raghav, is it you have done many cases or it's a single case?
No, I have done 2 cases, sir. This is the first case which I am presenting.
Okay. So both are only soft tissue causes?
Both are only soft tissue causes.
Okay. So what is the position you had? You had a position, I saw that everything was exposed on the back side. What was for the position of the patient for the scopy?
Sir, a prone position, sir. Prone position with a chicken wing position of the arm.
Okay.
These are the I did operate only 2 patients so far,
Okay.
but after this case, I'm focusing more on the scapular pathologists nowadays, and surprisingly, the number of snapping scapula have increased over recent times. I find a lot of people having snapping. They tend to ignore, and we ignore as well.
Operation operation correct.
Anything which if you try to focus more, you always will get more cases. No, it's like, if you subspecialize more, naturally that
Yes.
use more scopes and more exposure.
Yes.
I couldn't see any other question box in the chat box. John, any questions?
Just one question from my side.
Yes, sir.
Yes, sir. Good evening, sir.
It was an excellent talk, guys. I was just watching it.
Thank you, sir.
I mean, I have not done this procedure myself yet, okay? But how commonly you are doing now, this procedure?
Sir, as I said, I have done only 2 so far.
Okay.
I do convince after failed conservative for few patients, like 4 to 5 patients, I did convince, but nobody had turned up.
Thank you very much. Yeah.
Thank you, sir.
Raghavendra Ramakant here.
Yes, sir. Good evening, sir.
Yeah, good evening. Good presentation. I
Thank
have one question for you. Actually, most of the patients come with the shoulder MRI.
Yes,
They
sir.
don't come with the MRI for the scapulothoracic joint.
Yes,
which
sir.
I have also seen a few of the case. And
Yes.
most of the spine patients, cervical spondylosis also come with the pain in the scapular blade. So
Yes.
what exactly is your indication for MRI, and how you try to ask which patient to ask for MRI, or what is your this thing to identify this?
Sir, if I find something suspicious on X-ray of bony lesions, I did get for a CT. Only one patient had a osseous lesion in the ventral surface of scapula. But if on clinical examination, like for example, this case, there were multiple swelling on the scapula. He didn't have any other symptoms. All the symptoms were, focusing on the scapula. I did work for shoulder MRI, shoulder symptoms, coracoid tenderness. He had no symptoms whatsoever on the shoulder. All the signs and symptoms were in and around the scapula. So in such cases, I focus only on the scapulothoracic MRI, then going for a shoulder or cervical. This is purely on the clinical basis.
Okay. So what exactly you ask the radiologist to focus on, or what sections, or how do you ask for the this thing to compare it to the opposite side MRI, or what is a MRI you write for these patients?
I write scapulothoracic MRI, and of course my radiologist is doing a good work in this, and he is really helping me out in diagnosing, and he is focusing more on the scapulothoracic than shoulder itself.
Okay.
Okay, thank you, Raghav. It's a very interesting case.
Thank you, sir.
Tanmay, you can go for the last presentation. Can we go for last presentation? Shripad, can you share your screen?
Yeah, we can go with the last one. Dr. Shripad, you can share your screen?
Yes. Yes, sir. Am I audible, sir?
You are.
Yeah, please go ahead. Just click on the share screen.
Yeah.
Yeah, we can see. You can move to the slideshow.
Myself, Dr. Shripad Joshi. I am Associate Professor at MGM Hospital, Aurangabad. I would like to thank Tapasvi sir, Sundararajan sir, and IAS for allowing me to present this case. I would like to thank my resident, Aniruddha Patil, and Dr. Sachin Savji, who has allowed me to do this case, means Dr. Sachin Savji. This is a rare case scenario of association of posterolateral osteochondral injury of tibia with posterior cruciate ligament avulsion fracture with anterior cruciate ligament complete tear with lateral meniscus injury. So this, my case, 19-year-old female patient named Kaveri came to our hospital with chief complaints of pain, swelling or left knee since 6 days with history of knee dislocation following a road traffic accident. The patient was primarily managed in outside hospital with closed knee reduction, and above knee sleeve was given as told by the patient herself. No documentation and X-rays were available with the patient. So on local examination, when she came to our hospital, there was extensive swelling of knee joint with some sag was present, patellar tap was positive. There was tenderness around the posterior joint line on the anteromedial aspect. There was a contused wound CLW of 2 by 1 centimeter, which was sutured outside, and there was no distal neurovascular deficit. So how to manage it? So first of all, we had investigations like X-ray, left knee epilateral, then MRI. But unfortunately, I had no X-ray of this patient as it was a quite old case, and I could not contact the patient also. So this was the MRI image showing the first injury, the lateral meniscus avulsion tear from the capsular junction. This image showing PCL avulsion fracture with, as well as there was no ACL, complete ACL tear. And this was a type 4 osteochondral tibial plateau, which was flipped back posteriorly into the gastrocnemius. So what to be done? What are the options for going it? Either do single stage or to do 2 stage. As we thought that there are like first we should take care of the bony component. So we thought to do it in 2 stage to avoid a ligament reconstructive surgery, so that to avoid the stiffness, to have a better outcome for the patient, we decided not to do in single stage and avoid the reconstructive surgery, mostly primarily focusing on the bony component of the injury. So what we did, we decided to perform 2-stage surgery along as the MRI was showing capsule lateral meniscus avulsion injury. We did diagnostic left knee arthroscopy in supine hanging leg position. On diagnostic arthroscopy, we found a large posterolateral tibial osteochondral defect, which was confirmed. And along with that, it had a lateral meniscus, which was avulsed from the meniscocapsular junction and which came into the joint, came into the articular surface. So what we did lateral meniscus avulsion repair with outside-in technique using Whitfield 10 and 18 number spinal needle. So these are the images, arthroscopic images. You can see there was a huge posterolateral osteochondral tibial defect. And on the right corner, you can see that we have repaired the meniscus by outside-in technique. It was coming inside as it was avulsed from the capsular junction. So later patient was made prone and we did open reduction of posterolateral osteochondral tibial defect fracture, and we fixed it with the 2 cortical screws of 2.5 mm, and we repaired the PCL avulsion with 5 mm double loaded anchor. So this was the approach which we took. It was a posterolateral approach, and so you can see that osteochondral defect, osteochondral fragment was nicely fixed into the crater of the fracture, and the retractor is retracting the gastrocnemius, and the 2 screws we can see it, which was nicely buried in the cartilage. So the thing is that why we don't, as there, we thought Herbert screw will be a bit large, more difficult to put, as I thought it may crush the fragment. And so we fixed it with the 2.51, as there on table only 3.5 mm screws were available. 2.5 screws were not available with us, Herbert screw. So this is the first stage post-op X-ray, which we nicely fixed posterolateral tibial osteochondral fracture and the PCL avulsion with the 5 mm double loaded anchor. So patient was given good physiotherapy. We did static quadricep, hamstring strengthening. We achieved complete extension. Partial weight bearing with walker was allowed. Ankle pumps. All the physiotherapy protocol was followed for the 6 weeks, and we did a good score. So this was the image after the first stage surgery. That is, after 6 weeks, patient was evaluated. Patient was able to walk with complete weight bearing without pain. Patient was having flexion up to 120 degree to 130. Complete extension was possible. She was able to sit with cross-legged also, but she was having some kind of instability on rapid walking, and she was determined to join force as she was trying to get her opportunity in the police force. So she wants complete recovery as per her demand. So now we thought to go for a second stage surgery. So we did arthroscopic ACL reconstruction and we started the physiotherapy. So this was the second stage X-ray. So now you can see the patient had a complete extension, cross leg sitting, ability to squat without support, and she yielded a good functionals of knee. So what is unique in our case? In our case, it is a rare association of posterolateral tibial osteochondral fracture with PCL avulsion fracture, with complete ACL tear, with lateral meniscus avulsion. In literature, we have gone throughout a lot of literature, we have gone through a lot of papers, but most of the papers are presented on the multiligamentous injury with knee dislocation without osteochondral injury. Knee dislocation without osteochondral, but most of them are associated with ligament injury. There was one case mentioned about posteromedial osteochondral injury of medial tibial plateau with PCL tear, not PCL avulsion. And there was also not association of ACL tear also in that case. So in our case, posterolateral osteochondral defect probably prevented other ligamentous injury, and hence the fixation of fragment was essential, and to restore the bony anatomy was the most important thing before proceeding to some ligamentous procedure. In literature, most of the technique of PCL avulsion fixation are based on the screw fixation as well as suture pull techniques. In our case, we performed open PCL avulsion fixation using 5 mm double loaded suture anchor. The outcome was equivalent to conventional technique with advantage of avoiding intra-op complications such as crushing of the avulsed PCL fragment in screw fixation, difficult time-consuming suture pull-out technique in prone position. Then, in our case, ACL tunnel was bit posterior. I would have liked more ideal position, but somehow it was more posterior. But it didn't affect any outcome for the patient. And we found that in second arthroscopy, we found that lateral meniscus was completely healed and it was stable with synovalization of vicarial suture ankle. To conclude, most conclusion that we can make after careful analysis of case is that optimal operative strategy is most likely dependent upon injury characteristic. If to repair acute PCL avulsion fracture and rigid fixation of osteochondral defect with a staged ACL reconstruction was most important thing for stable, pain-free, and mobile knee joint. Operative times depends, however, it's not clear very much when to operate, whether to operate after 6 weeks, after 2 months, or after 3 months. But I would like as far as earliest if we are able to make the patient back to the normal level. We support early and stage intervention. This may reflect the fact that the surgeons has more flexibility in the techniques and in technique whether to do it an acute or to do it staged intervention. Thank you. So these are the references which I have gone through. Thank you, sir.
Thank you. That's a nice case presented. How was big? Actually, big was that fragment when you operated the chunk of the fracture?
So the
Can you
fracture
stop sharing
fragment
the
was
screen? Sripad, can you stop sharing the screen? There is a
yes, I'm.
Yeah, thank you.
Yeah.
Actually, the fragment has a good subchondral bone, and as we had operated her immediate after 6th to 7th day after injury, so it was a good subchondral bone with a good cartilage.
Okay.
So this is a PCL avulsion with osteochondral fragment with the
Yes,
lateral meniscus root. So we tend to see many times when there is a PCL avulsion fracture, usually that can have sometimes associated avulsion with the lateral meniscus root because there's closely attached to the posterior cruciate ligament. And sometimes you get this kind of osteochondral fragment too. Is it possible to do when you fix the open approach to the PCL avulsion and the osteochondral fragment? Is it possible to repair the lateral meniscus root at the same time open?
Yes, sir. Actually, the whole complex, like posterior root and PCL avulsion are like a one fragment.
Complex,
So
yes.
that anchor, using the anchor with needle is very helpful to fix root as well as the PCL avulsion.
Yeah.
What was your exact surgical approach?
So it was a posterolateral approach, modified means in that after taking the incision on the posterolateral aspect of the knee, that bifurcated common peroneal nerve, we can retract it, and I have retracted the gastrocnemius, lateral head of the gastrocnemius. So once you retract the lateral head of gastrocnemius, you are bang on the capsule, and just you have to incise the capsule, and you are in the joint. And as we have operated immediately 6th to 7th day after the injury, we are able to, most of the time, I think, I remember that capsule was injured. So it is very easy. Just the fragment comes in your hand. But in this case, I have to palpate under the muscle and retrieve the fragment, because it has gone into the gastrocnemius. It was not in front of me. It has gone into the gastrocnemius. So I have to palpate it and just remove that fragment. This is probably my third case. This was my first case, but I have done 2 more cases, such cases, with posterolateral tibial osteochondral fragment with PCL avulsion. But in other case, ACL was not there, but PCL avulsion with posterolateral tibial plateau. This is my third case.
Okay.
Yeah, it's a good, interesting case. Yeah, absolutely. Sometimes even you can do the minimal approach by transverse incision too, by just retracting the both gastroc. And naturally, your visualization is limited when you do that procedure. Of course, the extensive approach definitely helps you to everything to see and fix it perfectly. I think it's a good approach so that we could see everything all together with the osteochondral fragment, PCL avulsion, lateral meniscus root.
Yes, sir. Yes, sir.
Yeah. Interesting case. I have a question, Dr. John here.
Yes, John.
When you came second time, what did you do a dial test? And did you see how was your posterolateral corner?
Hello, sorry.
Did you do a dial test when you came for your second stage surgery?
Sir, actually, it was very difficult. It is a fresh injury, and it was very difficult for us. But probably I feel introp also, that lateral complex was not that much injured. That is, the posterolateral tibial plateau has prevented the posterolateral complex, rather, I would say.
With the meniscus also getting avulsed, so there was a soft tissue component extending in the back.
Sorry, sir, I am not able to hear, sir.
There is since a lateral meniscus was also torn from the capsular area, which we have told you prepared. So there is a chance of that also getting injured. That's why.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Later on also, when in follow-up, when we have evaluated the patient, patient is wonderfully walking on, she is absolutely was stable, and she didn't complain of posterolateral injury.
Yeah,
posterolateral component, I want to say that.
Yeah. I also have done few cases with same scenarios, and I have done the same open approach. I think I also not looked for dial test because they are all acute cases with the swollen knees, very difficult to examine. I think all these patients get, because it's a fracture, they all get some kind of 6 weeks and the fracture heals. The soft tissues also, most of the time it heals. Even we never had even posterolateral instability post-operatively. I think that was a wonderful case, Dr. Shripat Joshi. Very nice presentation. Tanmay, if there is no other questions, can I finish the session? John? Tanmay?
Unmute, sir.
Yeah, no cases in the chat box.
Okay, so thank you, Tanmay. Thank you, John, for your time and sparing time for Indian Arthroscopy Society Academic Corner meeting. I think it was a wonderful discussions of Dr. Subramaniam's talk on the partial cup tear and also these interesting cases by Raghav by scapularoscopy and Shripat Joshi with interesting case presentation. And we had a very good discussion on that also. Thank you very much, everyone. Good night and see you on the next meeting. Thank you.
Thank you. Thank you, Dr. Sundar.
Thank you. Bye.
Thanks for the opportunity.
Bye, John.
Thank you.
Bye.
Thank you, Sundar. Thank you, Tanmay. And thank you, John. Thank
Thank
you.
you, sir.